Okay. Hi, I'm Jerry Hesch. This is an interesting presentation. The name of it is Midfoot Rigidity from Inferior Fibula Fixation Causing Sesamoid Pain. I'm Jerry Hesch from the Hesch Institute in Henderson, Nevada, which is very close to Las Vegas, Nevada. And we treat complex chronic pain syndromes with a musculoskeletal cause. We also present workshops for hands-on clinicians. And this client did not come to see me for her feet. She came to see me for a hip injury and a sacroiliac injury. And today is day 2, and come to find out that she had a sesamoid removed in the right foot and started to develop pain in the left sesamoid and got a cortisone injection. Is that correct, that you had it removed on one side, or was it both feet?
Both feet.
Both feet. Okay, that was quite some time ago, am I correct?
Yes.
Okay. So she used to be an aerobic teacher, so there's a lot of high impact stuff going on, and a tennis player, and so there was a lot of start and stop motion, a lot of abrupt deceleration. She has very good mobility in the subtalar joint. Okay. She's a little limited in dorsiflexion from the ideal. I attempted to mobilize the talus posteriorly, which typically gives me a gain, but I didn't gain any with that maneuver. In testing the midfoot, I find her to be rigid on both sides. And this is a flexible model here. The midfoot, when I test it going into pronation, it doesn't go as it should, and same with an inferior glide test emphasizing the navicular. It doesn't move there either. The cause of the restricted midfoot can be the subtalar joint, but in this example it actually is from the fibula. Her fibula appears to be stuck in inferior glide, and that does restrict the subtalar joint mobility somewhat. It does restrict the talocrural or ankle joint mobility, and also limits the mobility in the midfoot. So I'm going to put the skeleton back up, and I'm going to have her lay on the table, and you will be able to see what I'm speaking of. I will then treat it, and we will film a post-treatment to show her response to the intervention. And I regret that we can't really show the treatment on film. For medical legal reasons, we cannot show that, but nonetheless it is informative. So please lie on your back. So my hope is that we prevent sesamoid pain in the future by restoring normative mechanics in the foot and ankle. And her forefoot is somewhat rigid. Okay, midfoot is distinctly rigid. I can bring it down to neutral, but not much beyond that. And when I work to bring it into inferior glide, it has a distinct rigid feeling. Now I'm going to suggest that she probably has a little bit of restriction in the subtalar joint. This might increase. At a glance it looks normative because she can go into abduction, and she can go into adduction, and she can go into eversion. Sorry about that, a little uncomfortable. I can take it into eversion, and if I block the ankle joint, I can still take her into a little bit of eversion. Again, dorsiflexion is tight, and that is to neutral. And if I try and spring the fibula superiorly, I can't get any mobility. There's a rare injury in which the fibula can get stuck superiorly, but it appears to me that it is in fact stuck inferiorly. I did test anterior to anterior mobility at the lateral malleoli and at the fibular head. Yesterday we actually treated the fibular head, restoring anterior mobility, but both of those seem to be normative today. So both feet present the same way. This one is rather rigid, going into midfoot pronation, and inferior glide is essentially non-existent. I also did screen the cuboid. She doesn't fit a cuboid syndrome. Seems to have good cuboid mobility on both sides. So we'll stop filming now, and I'm going to work on restoring this mobility, and we will film the results. Thank you.